This is Brian Ormers recording a lecture on the care of patients with pulmonary embolism. Some of our main learning objectives are going to be describe the diagnostic testing for patients with suspected or actual PE, identify priority nursing diagnosis for patients with PE, discuss and prioritize nursing interventions for patients who have a PE, identify patients at risk for a PE, teach patients about risk for PE and how to reduce the risk. So as an overview, talking about PEs, it's a collection of that obstructs the pulmonary flow. Oftentimes this can be clots, or it could be devices, or it could be other things that are just obstructing blood flow. As I said before, blood clot could be the main thing. It could be a fungal infection. It could be severe bacteremia. It could be a lot of different things. But blood clot is definitely the most common. Things that increase the risk factors for this would be prolonged immobility, so not moving, being bedridden, having any kind of CVLs or central venous lines, aging, conditions that increase clotting, history of thromboembolism, so if you've done it before, you're at risk for it, smoking, pregnancy, estrogen therapy, heart failure, stroke, cancer, and trauma. Anything that's going to increase your risk of having a blood clot. So with this, some of the things that you're going to see on your physical exam and have objective data for is that they're going to have they're going to have difficulty in breathing, and they're going to have a hard time catching their breath. They can have some chest pain with this. It's usually kind of sharp and stabbing, but it could be kind of a dull and achy one as well. Breath sounds are, you could have some crackles, wheezes, rubs. Oftentimes they've got hemoptysis, which is coughing up blood. And it can actually be some frothy, bloody sputum with this. You can have cardiac manifestations related to decreased flow. This is going to be tachycardia, syncope, hypotension. And oftentimes they've got some anxiety. Many times you can't breathe, that's a very significant thing, and people are very concerned about this. And it really has a high anxiety component to it. Some of the labs and diagnostics, if a P is suspected, of course you're going to get a metabolic panel looking at how they're doing on their chemistries. You're going to get a troponin to see how much damage there's been done to the muscle of the heart. You're going to look at BNP for that same reason. You're going to look at an ABG to get blood gas results and to see how they're oxygenating. A D-dimer looking at clotting. Another thing you'd probably get would be a CBC, looking to see how they're doing on their clotting cascades. Might even get a PT, PTT, INR, but you're going to want to look at those platelet functions of a CBC. Imaging, an angiography, of course, is gold standard. You're looking at where the perfusion is in the lung fields. CT if it's not available, or if you just are really short on time, or even a basic chest x-ray. But of course, gold standard is the pulmonary angiography. Alright, so nursing diagnosis, so you could have hypoxemia, so they're not perfusing well. And this is going to be evidenced by ABGs, decreased SATs, difficulty in breathing, level of consciousness. All these things could be affected with that. So our goal is to, increase tissue perfusion, having normal ABGs, having good SATs, having good breathing, lack of cyanosis. Interventions to try and help with this. Of course, reassure the patient. Elevate the head of the bed, apply oxygen. Just watch it on your COPD patients. Monitor the patient for any changes. Another goal would be, adequate tissue perfusion. So, looking at, once again, at ABGs, level of consciousness, all those kind of things. We can do drug therapy. Just be careful with this stuff, because with anticoagulants and stuff like that, you could get them to bleed in other places. But anticoagulant therapy is used to try and prevent more clotting, and sometimes fibrinolytics are used to break up that clot. So like alteplase is an example of that. So other interventions, I mean, we can use heparin, which is used to break up the clot. We can use low molecular weight heparin. Um, so enoxaparin or Lovenox is a common one. This will often continue. Sometimes we'll do heparin initially, bridge it for a few days because some of these other treatments do not work immediately. And so we'll bridge it with heparin initially and then taper onto a different program. Other drug therapy that we can use, just be careful, like I said, with that risk of bleeding. You have to be careful with that. So things that they might want to do, shaving uh, of their face, of their legs, those kind of things. You probably don't want to use a razor blade for that. Make sure that they're brushing their teeth with a very soft bristle brush. Watch out for any physical activity that they'd do where they could cause bruising or trauma to themselves. And just be careful all in all with falls or anything like that. So an NCLEX challenge question. So while assessing a patient who has been receiving heparin intravenously for the past 3 days, the nurse notes an IV pump is set at twice the required setting. What orders does the nurse anticipate from the prescriber? Which ones do you think will happen? Alright, so some of the answers and my thoughts on this is your PTT is probably your main thing to monitor your heparin, and that would probably be done. The provider may do an INR and a PT, but usually those are more with your Coumadin than with your heparin. Vitamin K and giving a dose to prescribe that can help with your clotting, as well as protamine sulfate, which is definitely directed at the heparin use. So my answers would be A, D, and E would be your main ones. All right, moving on to the next slide here. Planning and implementation. So interventions, we've got to be careful around surgery. If they've got that PE, you want to do an embolectomy, going after it and get it. Oftentimes it can be a non-invasive type of a surgery and taking tubes up the vascular system and grabbing it that way instead of doing a full-on open chest surgery like we used to. We also want to manage hypotension and hypertension related to this. So watch your fluids, give them as needed. Drug therapies, watch your vasal pressures, titrate as needed to either keep the heart rate or the blood pressure up or down depending on what's going on with your patient. Other interventions you'd want to consider would be, of course, health promotion and disease prevention to try to minimize future risks and occurrence of this. So smoking cessation, especially those that are on birth control, looking at increasing activity, reducing weight, and maybe even doing some Lovenox or some long-term care therapy for this. That concludes this presentation. If you have any questions, feel free to contact me.